Thank you so much for that introduction and for the invitation to speak. Oh, and there's so many friends in the room. So I wanted to start with my aims. This is the most text you'll see on a slide. Most of them are just going to be pictures to remind me what I want to talk to you about. But the first aim is I wanted to talk about a pathway for integrating health equity work as a subspecialist. I wanted to share ways, potential ideas on how to engage with your subspecialty societies, policymakers, patient and family groups to provide equitable care for children, and to think about the power of collaboration and inspiration from peer mentors, community partners, partners across the division, and partners across the department when you're thinking about health equity at Stanford and beyond. So that was sort of my CV introduction, and to give a personal introduction. And I wanted to start with like my version of why. It's like the Simon Sinek TED Talk, right? Like, what's your why and who am I? So as you know, I'm a transplant hepatologist. I am a daughter of a firefighter. I'm interestingly about to become the wife of a firefighter. And I'm also a mom. And so here I utilize that to say, like, this is who I am. And I was making a compelling reason to think about becoming an organ donor, which I am, and I wanted to talk about the reason that I am. One of my whys that I think about is that I'll mention next is thinking about like no child should die on the pediatric transplant waitlist, and that's my own reason for being an organ donor and talking about it. Again, when I think about my why, I like this quote from a physician that says, asking a doctor to practice medicine without social advocacy is like asking a pilot to fly a plane without looking outside. And that's so much about who we are and how we think. We have to think about that milieu as we're taking care of a patient, as we're taking care of a patient community. And then this is also why this photo took me a long, so I present this when I have done quite a few talks, and it always makes me feel emotional. I still feel emotional looking at this. And I was talking to my husband, who's not a physician, and he said, and this is a father taking his child to the OR to get a heart transplant. He said, that's so interesting that that still makes you feel emotional. Don't you experience that every day? But there's something about photojournalism like that summarizes all those moments that we have in one. And so that is the why. I came across this picture because a couple of years ago, I had a photojournalist who had developed this thing called the waiting list, and he wanted to give sort of the lay public an understanding of what it's like to be waiting for an organ for transplant. And he used to be at National Geographic, and so he was trying to utilize photos to tell the stories of patients on their journey to transplant. So this is part of my why. I didn't write this editorial, but I love this editorial because it's just to say, like, waitlist mortality in pediatric liver transplant, it should be 0. So how do we achieve that goal? This is the only brief thing I'll mention from my days before Stanford was that I did this paper when I was a GI fellow at Seattle, and it was with adult transplant hepatologists and 2 pediatric transplant hepatologists, and it came from the idea of talking about with the adult colleagues, we'd say, whatever happened to that one patient that transitioned care? And they'd say, oh, they actually died. And so it was just clinical or anecdotal, but the feeling was that there's something about the transition process, or there's something about that vulnerable age group within 18 to 24 years old. So as we looked at the UNOS database, that was true. They're more likely to die on the wait list. They're more likely to lose their graft, and they're more likely to die after transplant. And it's not that age of 18 to 24 where they're transplanted. It's like as they pass through that age, which we can all think back to that age and some of the risks that could be taken. And so that I mentioned that because when I first started here, there was a Department of Pediatrics meeting, and they're saying, introducing Noelle. And Noelle is a person who's interested in disparities research. And I remember thinking at the time, that's not how I identify, but that is how I want to identify. And so I think some of those early experiences became formative to who I've become sort of now early mid-career. So I wanted to tell this as a story. So there's some data, but this mostly just meant to be a story. And this is a story I put in 3 acts. So the first act will start with a subspecialist approach to health equity. So when I give this talk to trainees, I always talk about it's like Noelle sends an awkward email, or Noelle has like an awkward meeting. And this was not an awkward meeting at all, but it's just to say there were so many opportunities that were coffee meetings when I first started. And so when I'm talking to trainees, I talk about like, it's like the power of yes. You know, it's like you learn about the power of no, but sometimes the yes to these meetings leads to some really incredible things. And this is a really good example. And so I wanted to frame this. This is health equity, but this is, I think, what we all do, because my title talks about transplant, and I am going to talk about transplant quite a bit, but this is like rare disease advocacy, and I think we all engaged in this to some degree inside or outside of transplant, and this is the Alagille syndrome program. So I think we all, because we're at Stanford and because we all have very niche subspecialty interests, and we care for really chronic complex patients, that we're all engaged in rare disease advocacy. So when I met Jeff, he said, I'm really interested in Alagille syndrome. I want to help build this exceptional multidisciplinary care group. I want to advance research in this. And do you want to be a partner? And so the answer was, of course, yes. In 2020, we developed this Alagille syndrome program, and this is a picture of literally when I give talks about this, I say I'm standing on the shoulders of giants. These are cardiothoracic surgeons and liver transplant surgeons, an amazing multidisciplinary team that's already caring for these patients. And on the left, it's like what we do weekly. So we meet weekly, and this is our group of patient care coordinators and APPs, hepatology, cardiology, international medicine, to think about this rare population and how we give them safe passage as they come here from out of state, out of the country, through our system. This goes back to like my personal why. Like, why are you engaged in rare disease advocacy and or health equity related to a very specific patient population? Because of our expertise here at Stanford, I was invited to give this talk at the International Pediatric Transplant Association meeting in Austin earlier this summer. And as we're going through it, we're looking at this international registry data, and it says 8.5% of children will die before they're 18 years old with this syndrome. And that feels clinically true. As I can think of like the patient deaths or the losses that I've experienced over the last 4 years, there's quite a few. And then you go through, why is that? So 50% of them will need a liver transplant before they're 18 years old. 22% will die of liver-related diseases super young at 2.8 years. And knowing what we know from a cardiology perspective and the expertise here, my best guess is most likely they needed a corrective heart surgery to become a candidate for transplant. If they didn't get that for whatever reason, they died of liver-related causes. 90% of them will have a cardiac anomaly, and 18% will die from a cardiac-related death at a very early age at 1 year. So this is me giving my talk at IPTR, the International Pediatric Transplant Association meeting, and I was really proud of myself because having worked with Jeff for almost 4 years, I was actually able to present from a cardiac perspective. So I was talking about lung perfusion scans and going to indications for cardiac cath. And that I bring that back to rare disease advocacy and health equity, because you really do need, as a liver person, to holistically understand the whole patient, because I have to understand what their cardiac needs are as I'm having conversations with other hepatologists to advocate. They need XYZ to look at their heart so that they can become a liver transplant candidate. Going back to all-cause mortality, 15% have multi-organ failure and 18% of deaths were vascular related. And that just comes back again to the power of being in a place like Stanford and having multiple experts, both cardiothoracic surgery, liver transplant, and neurosurgery is another example. So as I was junior in this role and thinking about Alagille syndrome, I would think of some of the greats that have really been great mentors to me, like Benita Kamat at Toronto, and just understanding what we're kind of doing for imaging right now is we're saying they should be imaged, when they're 12 years old and they can go into MRI scanner without needing anesthesia. But going back to this slide, 18% will die of a vascular-related death, meaning like a brain aneurysm or other, at a median age of 2. So I think we had an opportunity to discuss with a neurosurgery colleague, Dr. Gary Steinberg, to think about these are the existing protocols, and we should probably be adapting these protocols because we're seeing such a high volume of patients here, specifically related to the pulmonary artery reconstruction group and the expertise in liver transplant. To go back to the why, I'm sharing this with the permission of the family. So sometimes my why is the patient that survived despite all odds, despite disparities in access to care. So this is a patient that was coming from outside the country, was on hospice, that's the picture on the left, had very severe liver disease, but they were coming for pulmonary artery reconstruction so they could be a candidate for liver transplant. And he had a living donor transplant from his dad, and he was here for about a year. He got his cardiothoracic surgery. 6 weeks later, got his living donor transplant. And then after a year of his whole journey with us, was able to go back home and is thriving and doing great. Sometimes I think about the why, and you're thinking about it from an equity perspective, or I think about it from an equity perspective. Sometimes the why is the patient that you lose, and you're trying to think, what could I have done differently? What can I do differently for the next one? And for me, and what felt like the inequitable outcome? And I think about that for Alagille syndrome as well. And as physicians, right, you think about physicians or surgeons, you think emotionally, there's always an opportunity where you say, I don't want to feel that again, and I don't necessarily want to be an expert in this syndrome where 8.5% are dying before before 18 years old, or you can really lean in and dig in. And so we leaned into it, and we went for a research grant from the Alagille Syndrome Alliance we described a novel protocol to decrease peri-procedural and intraoperative hemorrhage in children with Alagille syndrome, because that was our patient loss was related to a bleeding complication, and with a really great expertise here. So this is Claire Lowe, Mei Chen, Manchula Navaratnam, to think about what's the additional hematologic screening they should have. In the process of doing that, half of the children we found have this acquired von Willebrand factor deficiency. And so now, compared to a couple years ago, they go into the OR or to cardiac cath with a different protocol because this has been identified. And I should say that this idea came from cardiothoracic surgeons and liver transplant surgeons saying, we just feel like children with Alagille syndrome compared to those that don't are going into the OR and bleeding a lot more. So it came from a clinical indication, kind of an emotional indication, and then also a research now indication. I talk about the patient and family voice, or I will quite a bit, because it really informs what is top of mind for families, and it's really informing research. I think it always has, but it feels much more impactful now, at least in the liver sphere. So this is a patient and family group led by Roberta, who's our cover model here for our Alagille syndrome program, and this is their website here, and they are really driving research forward. You will go to meetings and you'll say, this is what we're kind of interested in, and they'll say what our community is really asking for is XYZ. So they've said things like, have you thought about the eyes? Oh my God, I haven't thought about the eyes yet. I thought about the heart, the kidneys, the liver. Have you thought about like developmental and behavioral pediatrics and screening and autism? No, we actually haven't. We need to build that into our clinic. So those partnerships have really meant a lot. I always love a photo shoot with Jeff Feinstein. If he's on, he'll be like, why am I featured so much? But we did this, and then we shot a video for a medical documentary, which is coming out shortly, related to Alagille syndrome. And that's really, again, just to speak on behalf of a community, inform our community, and really drive research forward. Okay, the second act, a team approach to health equity. So this is Amy Cuddy's TED Talk, which I think she talks about like fake it till you make it in power poses. And then this is always like, this is like also the Noelle's version of an awkward email. At least I love this because I put, it's July 1st, 2019. Like I didn't know where the bathrooms were. And I was emailing Lisa because I interviewed with her when I was becoming faculty here. And this has changed clearly the arc of my career, which I'll talk about a lot. But I only put this up for Lisa because I was talking about policy even back in 2019. And I remember meeting with Lisa, having a coffee meeting. And I think I said out loud, and I was definitely feeling like, oh, I'm not an advocate. I want to be, but I just like, I'm not. And that's the fake it until you make it part. And I think we all have that phenotype. So what I put in the title was like, this is accessible. I remember thinking, I don't have a master's of public health. I have not done this before. So many of our trainees already have this experience. I don't. I think we all have that phenotype, and it takes a special person to help foster that, which for me has been Lisa Chamberlain. So we got started. We created our Peds GI advocacy group. It started in 2020, I think, officially, and it still meets, and we meet monthly, but this was like our initial group. And we meet to do things in person. So sometimes we're like, we're doing physical things with our hand. We're making newborn bundles for the NICU or the newborn nursery. Here we're doing, in 2023, we set out on January and we said, what are we really interested in? And we said, this year we're interested in LGBTQ+ youth, and thinking about like how our clinic, because we all see such chronic patients, like sometimes you're seeing them more than a pediatrician. So we wanted to know, what should we be talking about? What's the prep clinic? We wanted to learn what's gender affirming care look like at Stanford. And so we have had meetings designated for that. Here we're sorting books for our GI libraries, so we can give all kids books that come to our clinic. We've had invited speakers, Drs. Christy Sandberg, Benjamin Laniakia, Megan Bowe, and then Aliyah Bhatia, who's the executive director for Vote ER, just thinking about civic health engagement and work that my colleague Shweta Namzoshi is doing a lot of work with. We have our own website. It's myself, Shweta Namzoshi, and Rachel Hurdes are all co-lead our GI advocacy group. And to our knowledge, it's the only one in the country. So sometimes we have folks from other divisions that'll come to our advocacy meetings just to listen, learn, and sort of bring that back to their divisions. And as we were doing this, we said, we've been doing this for a couple years. We want to share what we're doing because we think we may be the only ones doing it thus far. And so we we submitted a paper to our national society or our own journal, which is the journal Pediatric Gastroenterology Nutrition. And they said, oh, we're going to pass on this one. So then we submitted it to a different journal, also passed. And then we took it back to our own home journal to say, when we look in health equity and advocacy, when we look at what has been published, we see maybe 1 or 2 articles related to magnet ingestion has been a really important thing and legislative thing for peds GI, but we only really see 1 or 2 articles, and we're wondering, do you actually have a home for equity work and advocacy work? And they said, that's actually a really good point, and we would like to invite you to write a topic of the month. So that it didn't have to do with our paper. We really just wanted to say, we really need a home for health equity work. Can you provide that? And so we'll be publishing this, a guide to prioritizing health equity and advocacy in pediatric gastroenterology, hepatology, nutrition. And I only say that for your own societies. If there's not a home, sometimes you have to make that home. As part of our GI advocacy group, we started doing paper screening, knowing that the epic rollout that Baraka Floyd and Lindsay Stevens had led so much on was coming for food insecurity, but we wanted to start with something. And so we did a paper screener, and really from working with Baraka and Lindsay both so closely, we also wanted to be sure that when we were asking the questions that we had the answer or the tool to give to families afterwards. So this took a lot of work with medical assistants, front desk, clinical operations, leadership, talking with our division, working really closely with our social workers. This was rolled out both in our GI and liver transplant clinic. And I think it was the first paper screener, at least, to do full social determinants of health screening around 2020. And then we took it to our division. We said, if you see the screener, we want you to understand what it is and why we're asking about this. So we, 1 in 6 children experience food insecurity. There's racial and ethnic disparities in it. There's a higher prevalence in the populations we take care of. Inflammatory bowel disease, celiac disease, fatty liver disease, and hunger is a vital sign we should be asking about this. As with everything, it feels like in health equity advocacy, you peel the layer and then you see the next step or thing that needs to happen. So then Shweta Namzoshi, my colleague, and I are very interested in food insecurity. And I bring this up because she talks about it all the time, of the idea of team science. And we really take that to heart, meaning that there's always a team, right? So if one of us is on inpatient service or one of us is flagging, the other one sort of rises up and carries that ball forward, and then we keep passing it off. And that's been a way that we, at least in health equity and advocacy work within our division, have been able to keep it sustainable. This is me literally highlighting a failure, but we're so proud of ourselves. We submitted for a Robert Wood Johnson Foundation Healthy Eating Research, which was a moonshot, and we recognize that, and was probably, I don't know, the hardest grant that I've worked on, which we definitely didn't get, but it was a start, right? You have to start and fail to learn and get better, and we have a lot of people that helped us in that application, and we're going to keep submitting. Okay, my story in 3 acts. Act 3. A policy approach to health equity. This is my favorite part. So I wanted to start by defining policy as it could be institutional, it could be societal, related to your national society, and it could be legislative. So I think I have a couple examples for each category. So in 2023, was so honored to be invited to be the co-director of policy alongside Shweta Namzoshi in the Office of Child Health Equity under the direction of Lisa Chamberlain. And this will be a story for different grand rounds, and these are their stories, but I just wanted to highlight that because I mentioned the power in health equity of peer mentors. So these are people that I really admire who are health equity champions for their division, working with the Office of Child Health Equity, who have very defined expertise in all these spheres that you see. So Dr. Irene Lowe, Tina Busey, Rebecca Kamini, and Ananta Adala, I've learned from each and every one of them. So it's definitely bi-directional. They've worked on things related to policy for dyslexia screening and getting AEDs and CPR teaching in high schools, and thinking about having Cellucortef as part of emergency medical services. So really, again, going back to the idea of peer mentors, team science, and learning from each other. I had the pleasure, so this is kind of I wish I could have done this in residency, but now I get to do it as a faculty member. So going to Sacramento and talking to legislators. This is California State Assembly member Mark Berman, and we're here with the resident and other members of the Office of Child Health Equity. But just being able to go, and it's almost like an elevator pitch. It's really short. You're trying to give your one-liner. It's like going back to presenting on rounds when you're first learning. This is what we're interested in. This is the data, and this is the ask. So just a really good experience experience for anyone. And then I just wanted to comment that we're always working with Sherry Sager in government relations to say, if we're thinking about something related to policy, we meet with her weekly to say, we just wanted to bounce this idea off of you and understand what's possible, what the next step is. So it's always in conversation with her. I mentioned infographics because I had an example of like a horrible infographic I made myself, and then I utilized Canva because Shweta taught me how to do that, and it just looks so much better. So thinking about if you're doing something that's research related and you want it to be lay facing, or post something via social media, or give it to a staffer, or give it to a legislator when you're going to Sacramento, the future, as we say, is visual, right? Like this is such an easier way for them to digest it. So these are from our cardiology colleagues related to their work on CPR and AEDs and gun safety, and both were bills that we're going through this year. I wanted to take it back to subspecialty societies and policy work with a concrete example. And this is again, like Noelle sends this awkward email in 2020, but I was really talking about, I like this because I think I closed on it eventually, right? So I was like, dear my national society, I'm just a junior faculty member, and I'm really interested in health equity and liver transplant, adding a couple folks that have subsequently become really great partners and research collaborators. And I'm talking about exception score requests. And now 3 years later, there's a paper related to that, which I'll highlight. But I think going into my subspecialty group, saying like, this is kind of who I'm identifying with or this is who I identify with as a person interested in health equity. Are there any partners out there? We've all sort of found each other over time. So this is a federal bill that was reintroduced in 2023, and it's a bill related to living donor transplant. And I wanted to utilize this as an example of thinking about legislative policy and how impactful it can be on the day-to-day and addressing disparities in health equity. I won't make you read any of this, but this is just a one-pager. So I said, I'm interested, this is a federal bill. It's been around since maybe 2013. It hasn't passed in a decade. It's really not, it's something that's been well supported by a number of societies, but how can we keep trying to help? So I went to my Pediatric Society, which historically hasn't, I don't think, formally supported this bill, but was very much in favor of it. And so we did a one-pager, right? It's just like that leave behind, that if you're talking to a policymaker, you're leaving that behind. If you're talking to a liver advocacy group or kidney advocacy group, you're leaving that behind. And we just summarize like, it's like writing an op-ed. It's like, what's the problem? Why should you care? Children are dying on our pediatric transplant wait list. That's going back to my why, right? No child should die. Did you know 10% of children under 2 years old die on the wait list? That should never happen. 5% over 2 years old die. We believe, underline, no child should die on the wait list. Here's the solution. Living donation, and you have to recognize, like, we're talking amongst ourselves as pediatric transplant hepatologists, but you're talking to someone who knows a lot less about the power, how you can do living donation. So just to say the solution, did you know that living donation is safe? You may be aware a person can donate a kidney, but did you know a person could donate a part of their liver and both do great? And actually the outcomes for living donation is better than for deceased, but only 12% of transplants right now are living donors. And there's a lot of barriers, and here's why. Then we go, it's like, what's the facts, right? You sold them on the emotion of it, but what are the facts? So only, let's see, a quarter of living organ donors were rejected for insurance coverage or were discriminatorily charged higher premiums in 2021. Very few states provide any protection from insurance discrimination. Only 2 states provide FMLA. So can you imagine you're like donating to your baby, but you don't have that time to recover afterwards? So these are the barriers. And most importantly, we always put like, this is the health equity reason. Children that are Black and Hispanic are more adversely impacted. They're half as likely as a white child to receive a liver from a living donor. This is a major health equity issue. Then we talk about like, what would this bill do? This bill would make sure that there's no denial of insurance coverage, that there's FMLA for patients, that there's actually more education to families. And this is our ask. As a Society of Pediatric Liver Transplantation, we are urging Congress to pass this act. And then at the end, we just put, who are we? We're split. We were founded in 1995. We are encapsulate 40 transplant centers across North America. We've cared for over 3,400 pediatric liver transplant patients. We care deeply about these children. And then we also signed it with our patient and family voice group, because these are parents. And we were talking to, our adult group is called ASLD, but it's just the adult version of our group. And they said, we go to DC every year and we would love the pediatric voice, because it's like you go into an office and it's a parent with their child. I donate to this child. These are the barriers that are faced. And these are ways that you can make it easier for parents like me to be able to donate to a child and save their life. And so our patient, family, and engaged partners group signed on with us. This is going back to just a infographic to say this summarizes in a way that's easier to see. You can see like 10% of children under 2 die, 5% over 2 died, only 12% get a liver transplant. I quoted myself, which is so awkward, but I did it. And then the health equity issue, like Black and Hispanic children are half as likely to be transplanted. These are statistics. This is who we are. Here's our website. And it's just like a more visually appealing version of what I showed. Oh, this is the ugly version I made by myself on Word. So you can just see like, it's so much better. Then my National Society, they put on their website, like if someone's Googling this, we want them to be able to come to the Split website and see how we care about this issue. And then we made an academic product out of it. We went to the American Journal of Transplantation, which is one of our highest impact journals, and submitted it, which is currently under revision. Federal action is needed for equitable access to living donor transplant. We hit it in so many different ways so that it was across our community, across the lay public, and legislator facing. Ken Sutha is somebody, so there's so many people I met that I admire so much, and I feel like Ken, if you're listening, Ken, I've never gotten to talk to Ken in person, though he's been so nice to email with me, but he's doing such amazing work, because this is a liver issue, but this is a kidney issue too. So he is in Washington, DC. He's such an amazing advocate, and I can learn so much from him. So I think the more you put out what your interests are, what you're passionate about, you find your people. And so it's been a real pleasure to learn from him in this. Every opportunity I get, so I'm like giving a talk, it always has a little health equity line. April is National Donate Life Month. I'm doing a video and I'm talking about, the prompt is, why do you care about living donation? I'm like, that's a great question. Let me explain all the things. This I love. It's like Noelle Ebel. I'm like, no, it's Noelle Ebel. But just every opportunity to say, I want to talk about organ donation. I want to talk about why living donor is so important. I want to talk about why kids should not be dying on the wait list. Alok Patel has been a great person, bless his heart, for teaching me how to make a video for social media related to this, and it's just been a great resource here at Stanford. I wanted to talk about disparities research, because these are opportunities that I've taken. So this is an invited editorial with Evelyn Su, who's one of my mentors from Seattle. And then Allison Kwong and Ray Kim are leaders when you're thinking about allocation, how they're changing on a national level, allocation in MELD 3.0, and gave me the opportunity to help write this annual data report that comes out. And so in an editorial, of course, and this is with Peace DK, in this editorial, it's an opportunity to just say, you're talking about the data, but you're just saying what really needs to be said. So that was a wonderful opportunity. For the SRTR, it's not an editorial, but I always put something in there. So I say, like, this is the data, and in 2021, mortality rates for Black children have improved since 2014, but this does not fully capture. And so it's not an editorial, but it's just saying, from my experience, for everything that I know, there's still disparities still exist. This is critical to ensure equitable access. So I put that in everything that I touch, because it's really important. All right, the next act. This was a review article that I wrote with a colleague, Sharad Wadwani, at UCSF, and some of these authors are people that I put back in that 2020 email to say, like, are you interested in this too? So we had the opportunity to review the literature and be really prescriptive. So what I really appreciate about the editors for this journal was we sent it in and we were pretty prescriptive. They say, we need more. Like, the reason we're asking you to write this review is we want your opinion on what the next steps are. So we summarized, where does the data currently stand? Currently, non-white children are sicker when they're referred. They're more likely to die on the wait list. They are less likely to be petitioned for exception scores. So for those not in transplant, it's a bit of a subjective essay that you write to a committee. And so it really takes ownership from a human to do that, and children that are not white are less likely to have somebody do that, submit that on their behalf to get more points, to get a transplant faster. Non-white children are less likely to be the recipient of a living donor, as we talked about. They're more likely to have graft failure. They're more likely to die after transplant, all compared to white children. And so in that paper, we had multiple bullet points. And as I was making this presentation, I realized I took that as a letter to myself, because I think sometimes the hardest part of writing a discussion is you're like, and then the next steps are X, Y, Z, and someone else should take the baton and move it forward. And we've really taken the opportunity to be the ones that continue to move it forward. So some of the things we said is, you have to address the role of racism in inequitable liver transplant outcomes. And this is not by any means a solution, but it's a start. We, through Split, we said we want to do a workshop. This was led by Hannibal Pearson, who's an amazing person who's both double boarded in peds GI and pediatric psychiatry. And he has led this workshop and created this space and opportunity to have people come in a space that feels safe as transplant surgeons, hepatologists, nurse practitioners, anyone involved in a transplant team, to really talk about, let's address racism and bias in pediatric transplant, and let's think about where we need to go next. We talked about in that paper, you should be screening for adverse social determinants of health, but you shouldn't be utilizing them in any punitive way. So it shouldn't be, this family might not, there's not enough care providers, or they don't have access to transportation, or we're worried about compliance. It shouldn't be a punitive assessment of that patient. You should be getting that, you should be asking for what are your barriers to best possible outcomes, so that we're addressing that on the pre-transplant side. That's the reason to ask, to address, to improve their outcomes. And so we did a national webinar via Split on that as well. We talked about, you should be prioritizing the recruitment and the retention of diverse hepatologists and surgeons. And so this year, as a program director, I recognized, looking back at past years, and we looked at the data for a long period of time, we do not have diversity in our field, and this is the future of our field for equitable outcomes. And so I got a couple of grants this year to have it was open to medical students, pediatric surgery residents, GI fellows, pediatric residents who I self-identify as being underrepresented medicine, to come to our Split National Conference. And so we have 2 recipients this year, and that'll be sustainable moving forward. We talked about in that paper, there are racial and ethnic disparities. There are also geographic disparities. And we do a really good job at Stanford with that. So these are all the states. Everything in sort of gray does not have a transplant center. And we are doing our best to provide equitable care by physically going to these states and meeting families where they're at. So Hawaii, they do not have a transplant hepatologist. Oregon, they have a hepatologist, but they don't have a transplant center. So we physically go with surgeons to see families and move them here when they have to. And these are all the outreach sites that we go to try to break those geographic barriers, because the further you are away from a transplant center, the worse outcomes you're going to have, the less likely you're going to be listed and or survive until transplant. This one is a work in progress. One of the last points that we put was, we need to have a health equity dashboard with center level data for accountability. You have to have it be visible so that you are accountable to those disparities. And there's a couple of ideas or paths on how that could happen. One is the Starzl network. So a lot of, I can think of examples in cardiology and across a lot of specialties, where you have a national quality improvement network that has access to data, that has a patient advocacy voice, that has an interest in that. And I think this will be housed under Starzl shortly. You can look at, like, in the United States, you have a group that is collecting data on this, and they started to have a liver equity dashboard, or like it's for all of solid organ transplant, but it didn't look up to date. So the idea is there, but I don't know that it's been operationalized yet. And then I wanted to give, a shout out to who I think, so we're talking about the frontiers of health equity in pediatric transplant. I have been able to make a health equity dashboard. I think Peace is going to be the future of this. And I think she's going to be basically leading on a national level. So she was a recipient of the MCHRI Community Engaged Research to Promote Health Equity pilot grant. Part of that is for the creation of a health equity dashboard to detect real-time racial and ethnic disparities in the pre-liver transplant period. This coming weekend, she was an invited speaker to Split. So our national society already has a national reputation in Montreal to talk about the imperative to address health inequities in pediatric liver transplant. So putting her out there as a future grand round speaker, I'd love to nominate her. This is my last slide. These are future initiatives. So I talked a lot about, I went through like most of the aims, but the one I didn't really hit on, because it's the one that is still, I still want to do, is thinking about cross-departmental. And a lot of people do that beautifully. I just haven't done it yet. But first, before that, within the department, I think there's an opportunity. So we have this pediatric transplant center. It's across all of solid organ transplant. People are interested, and there's this idea of talking about health equity. We've already talked about at these executive meetings. across all solid organ transplant with the Office of Child Health Equity, thinking about what we can do as a group. We are the transplant center, the center of excellence at Stanford, with some of the highest volumes, and we care about health equity, and we're putting that back out. I think we can lead in the national space. And then across the department, when a couple years ago, and I just emailed him last night, and he just responded. He's like, I'm at Harvard now. Okay, we can still collaborate. But I'm really interested in Stanford economics. So he reached out to me a couple years ago. His name's Alex Chan. And when I was Googling him, he subsequently developed a really interesting algorithm for a three-way liver exchange that I think was international. And he said, you don't know me, but I'm interested in transplant. We have this like national meeting that we do, and Al Roth, if you know him, is there. So I had to Google Al Roth. Oh, Al Roth won the Nobel Prize in 2012 in economics, and he changed the way kidney transplant is allocated. I'm really interested in economics, the economics of transplant. So I think there's a lot of cross-departmental folks to collaborate. So that was my last slide. Happy to answer any questions that you may have.
Just to hear, I think. Can you hear me? And thank you very much. That was excellent. The floor is now open to questions. There's a roaming microphone here. Please.
Oh, Noelle, thank you so much. What an exciting horizon you've painted for us. Lisa Chamberlain, General Pediatrics. I have a question about UNOS and how they have engaged with you on this, and or thoughts from a kind of systems level change there.
Yeah, it's super timely because there is, from a federal perspective, there's going to be a reconstruction of this. I'll say that first. The second is, it's kind of the philosophy of, so there's definitely work to be done on a federal level. And there are so many people that have mentored me. I think like Evelyn Soon, Emily Preet are two that come to mind, where from a national perspective, that's the right next step. And especially as you're thinking about policy. And so they have very much encouraged me to be a part of those conversations. And I think then the answer gets really interesting because from a national perspective, sometimes what you're advocating for it's really big to start. So it's like a big meeting of adults and they're thinking about allocation, and we make up a much smaller minority of just the number of transplants. And so when you're thinking about health equity, my brain has to expand to be like, first you're fighting for children. And then once you've fought for children, then you're talking about the next layers of those adversities and barriers. So I think there's a lot of work to be done from a UNOS perspective. There's national committees when you're thinking about some of the things that are coming up, those public comment that I think when we think about the transplant center, so like Split, for example, will put in something if they say, we're thinking about changing allocation, and then you say, this is how it would impact pediatrics, and we'd like you to consider this. It's so there's opportunities to make a public comment from a Stanford perspective, meaning I think we're already doing that well from a national society perspective to say, we're speaking on behalf of children, but I think we have a lot to contribute from a Stanford perspective to some of those public comments or national things related to UNOS. Thank you for that question.
Hi, Noelle. I'm John Klein. I'm the new Adolescent Medicine Division Chief.
Hi.
My first grand rounds.
Ooh.
And that was a wonderful presentation. How do we, as advocates, balance multiple issues? And how do you think about sort of these priorities, which are so important for this population, and balancing it across all of the other issues?
Oh, interesting. And by other issues, only to make sure I answer your question correctly, do you mean like other things that you're like, as a kid,
any other need that any other population of people living in disparities have to have advocacy for?
Great question. How I've thought about it personally, and I give this talk to the trainees because I'll say like in 2019, and I'll show this Venn diagram, and it's like, these are the 4 or 5 things that I'm interested in, and then like slowly as the years have gone on, it's literally 2. So I still keep health equity one, which doesn't really answer your question, because you're like, that could be any single question. Then I'm like, my other sphere is heart, liver, and so when I'm operating as like a single person, I'm only staying within like the center of that diagram. So I'm like, the issues that I'm going out on are like heart, liver related, I guess I would put transplant there, and I would put like Alagille syndrome and combined heart transplant right in the middle. So that's like how my brain lies. Though under the Office of Child Health Equity, it's had to flex in a different way to think about, as we're working with cardiology, endocrinology, it's becoming facile and nimble to say, if someone brings up an issue and it's a timely issue, meaning like this is a policy or this is something that's going to Sacramento or it's about to be voted on, then there has to be sort of a nimble ability to think about like, we're learning as much as possible to go to the right person to advocate for it in the right way. So that's not a good answer to your question, because really the answer is, at least what we're trying to do in the Office of Child Health Equity, is to always have the flexibility, but as a human to be able to be impactful and being an expert in just one thing. So folks will be like, if I'm thinking about health equity in this one thing, I'm probably going to ask Noelle about that. That's how I've tried to protect my own spheres personally. I also want to make a comment, because it's so nice to meet you, that I am Scott Hadland had given grand rounds maybe before you were here, but he's adolescent medicine. I think he's the chief at MGH. And I recently saw him at a transplant congress, and he gave a great talk here. I think he was like talking about fentanyl and what we all need to do as pediatric providers. But I saw him at like a transplant congress, and I think that's just my way to say, and I knew him from Boston University, is that folks that are in spheres that maybe feel very separate, we're starting to come together. So that I definitely have partners in adolescent medicine. So it's a pleasure to meet you.
Thank you, Noelle, so much. This was incredibly inspiring. And I think the most inspiring part is really just, especially as a junior faculty member, you highlighting the collaboration that can happen interdivision, interdepartment, on a national, international scale. And I think that's part of the answer, really, is that one person can't do it alone. And this is what you've highlighted throughout your entire talk. That wasn't my question, though. My question was about how and if there's a role to expand advocacy on an international stage, especially within our small little niches. Not all, but the majority of our medical data, our patient care focused organizations are typically country-based. And we know that there's disparities that expand way beyond the US, especially when it comes to organ transplant, but in other realms as well. What are your thoughts about how we even begin to address those?
Ooh, that's such a good question. And so two answers to that. I think one, this is like the part where I say, like, as you peel back the onion, there's something next that you're like, that is so horrible. And that you're saying, like, I only have a few spheres, but now I'm actually really worried about that. So example that comes to mind was international. And it was a person that had found my email that said, I'm a general surgeon in a country in Africa, and I actually don't have a transplant center within my institution, and I want to be trained to serve my country. But in the time being, what I really want to know is how I can get a child with biliary atresia that we know, right, as transplant hepatologists, will die without surgery to a center. And so it's starting to, I think that's the power of Stanford. So it's leveraging something like Carlos Escobar, who's a transplant surgeon, as you know, and was the past president of the International Pediatric Transplant Association, to help that one child. That doesn't, it's like, how do you plug in and think about things on an international level? To answer your question, I think there are groups, and I found them to be, because you're right, like Starzl and Split are North American societies, but the patient and registries, at least the ones that I can think of applicable to heart, like Alagille syndrome, those are international registries. I'm interested, I don't know if like is CERTA international? Okay, so then it's just say like, and I'm only highlighting that because Dr. Zhang is the intestinal transplant director, and so she is in such a niche of transplant that is already nationally recognized, and she's already doing amazing things here that are advancing care for intestinal transplant, and you're thinking like, how can I help others in other countries who have my same niche interest as a rare disease advocate? I think it's through things like CERTA, which is your international organization, and the patient and family voice, and registries, which maybe the registry exists or doesn't exist. Yeah.
Thank you.
Hi, Noelle. Hi. Fantastic talk. Hi. I'm Mark Melcher, one of the adult transplant surgeons. Your talk made me really think about how we could apply what you're doing to the adult side also. There's obviously, we talked about this yesterday a little bit, that the advocacy is really important, and there's clearly just multiple initiatives that we could probably do. My question though is, so Al Roth is been subtly advocating for paying donors, paying living donors some sort of fair fee for making donation. As you know, the donors are probably the only ones not not making money in the situation, probably the only ones who are making a huge sacrifice in those situations. And I think you can make arguments on both sides, whether or not increases inequities or actually decreases inequities. What are your thoughts on that?
Ooh, that is an interesting question. Okay. Well, one, I just really want to be in a space with L. Ross first. I mean, I guess the first thing that comes to mind, you'll have to tell me your opinion after this. The first thing that comes to mind is that it's like when you're doing a trial and you're paying a patient to be a part of that trial, but you're not paying them something so much so that you're causing bias or having them feel compelled to do something. Living donation is hard because, like, as you're even more aware of than myself, there's always some risk. It's always a benefit to the recipient. So that's why it's like, for the audience, it's like pediatric is separate from adult. So we're not a part of the evaluation at all because we have a vested interest in the child, so that the adult being worked up for donation has to be fully separate from us because we're biased. And so then you think about, is it a situation where that person accepts, often it's a parent, but sometimes it's an altruistic donor or someone that doesn't even know the child, they're accepting some benefit. So it's like I think I'm stuck on like the ethical principle of it, and having that person be compelled to put themselves at risk. Separate but kind of related is, I think, the idea of altruistic living donation, which for our audience may know a little bit less about, but there's certainly places like Toronto and Colorado where they have someone that just says, like, I don't need to ever meet this child. In fact, I'm not even like allowed to, and I have to go through a full psychiatric evaluation, but I really just want to save a life, and I want to give a little bit of take some acceptable risk to save the life of a child, but I don't know. That's altruistic donation. And I think the part of that, like the reason that they don't meet initially, is because it truly has to be altruistic. There can't be anything in it for that person. So I'm thinking about like financial compensation for that. It sorts into that category. And then the next thought I had after you're saying that is like, but maybe there's other ways. So it's like, why would we have to, why are we thinking about like the paying them? It's like, is the reason because like you were saying, there's the least in it for them. So is that the systems thing? Is that the policy thing where you're like, if they just needed FMLA and protection of their job, or better support, or more protection, or lower insurance premiums, like what's the derivative in the upstream issue that maybe circumvents that ethical issue? I'm interested. Do you have an opinion on it? I'm curious.
I think a lot of people talk about making you whole, so there's just making you whole. You're out of work for a few weeks. Do you pay that income in that time? Do you pay for housing locally and stuff like that?
Yeah.
And even there we struggle. So that there are networks that pay for that, but you have to be below a certain income. And for example, in the Bay Area, that income is so low that there's a lot of other people that will suffer above that minimum income also.
Yeah.
I think it's kind of taboo in our field to talk about it, but giving more money above that, I think it should be discussed. I think it's so taboo that we're not having an open discussion about it. That's one reason I bring it up. And Al Roth has been pushing it subtly for years. There's more people who push it more heavily, but he's constantly promoting these other people that are pushing it. And of course, he's thinking from an economic point of view. So
that's interesting.
And Alex has too, actually, to some extent. So thank you. Great talk.
Thank you.
Let's get a question from the online audience, and there were quite a few. In fact, I'll combine the two questions from Nicholas Dimerets and Helka Goyal. Both of them say, what an excellent talk. Thank you. Inspiring, impressive work. The two questions are sort of interrelated. One is from the viewpoint of pediatric lung transplant, and the other one is from non-liver transplant. Question similar though. What can we learn from your experience from Algeals or from transplant health equity research? How can we apply what you've stated here in this talk to our own fields? Is there sort of a pathway? Is there a program? Is there some sort of method of accelerating what you've done over the number of years?
Oh, interesting. Hi, Nicholas. Hi, Elka. I love that question. So I think like one thing that we have learned that now, like in pediatric transplant, I feel like we're trying to model is that you have a multidisciplinary group that meets weekly, and the learning is like rapidly accelerated. And by that, I mean, from where we started in 2019, when we started doing these meetings and we're talking about these patients are bleeding more, it's like, Well, now we have hematologists that are part of this, and now we have research, and it's just been so accelerated by having that simple space to talk through kind of the hard patient cases. I think our role when we first started it was literally for safe passage, so that when we go to cardiothoracic surgery conference, and Mike and Frank and Elizabeth are saying, can their liver withstand bypass? Like, the more you go and we hear the questions being asked, the more we're proactively being able to answer them. And I don't know if this gets to the heart of Nicholas and Alka's question, but one thing we've learned is that, as happens a lot at Stanford, patients are coming from out of state or sometimes out of country, and you're like, I have a restriction and I can't do telehealth, or sometimes I don't meet you ahead of time. But we do so much in these pre-meetings so that we're like, we have heard your name 25 times before you get here to think about safe passage. I think that's the model that I think of. So again, it's just being a part of a multidisciplinary team, and then really sitting and having a space. We do 30 minutes once a week to talk through every patient, to be like, did we think about their kidneys? They're going to meet Cynthia Wong when we get here. Did they get their hematologic screening in advance of their home institution or their home country? What is it? That's what we're trying to bring into liver transplant too, because I think it's just a space to sit, think, pre-plan, and get ahead. And it has to do with how they do when they get here, and sort of equitable outcomes when they get here, despite being a patient that is not living close by. So I guess that's how I would translate it to other programs.
Well, thank you. It starts by asking the questions, and perhaps more symposia or grand rounds of this type. And there's one more question, perhaps where you may end after your question.
So Sunny Anand from Critical Care. Really enjoyed your talk. I'm sorry I missed the initial portion. My question was in terms of post-transplant long-term outcomes, educational, developmental, social, relational health. Is there a pattern of inequities that we see in children, who've been transplanted, say, in their early part of their childhood?
Oh, interesting. And tell me if I'm getting to the heart of this. So I just had a meeting with Mihaela Damian, and we were talking about, within the transplant world, I think when someone from critical care comes, they're often talking about the time to extubation. She's like, you know what actually is the more important question is the neurodevelopmental outcomes afterwards. And so she's part of the Starzl network, and I think she's the only intensivist that's a part of that. But she's like, if you want critical care involvement, which is a huge piece to their excellent long-term outcomes, that's the heart of it. So I think we feel really fortunate in liver to have someone, especially someone from Stanford, who's like leading on a national level. When we think about like the disparities going forward, Vicki Ng, who gave grand rounds here a couple months ago, is a transplant hepatologist at Toronto, but she has written this paper where it's like, what's the ideal 10-year outcome and who's meeting that, who's not? And she's like, the ideal 10-year outcome is like, you still have the same liver you're transplanting with, you didn't need a transplant for another indication like kidney, your liver numbers are normal, you didn't have PTLD, and I don't think there's a neurodevelopmental component to that, but there should be. But when she looked at that, like the disparities are huge. So you would say like non-white children, in fact, race and ethnicity was the only thing that best predicted worse 10-year outcomes. So there are huge disparities from a long-term perspective for liver transplant, absolutely.
Yeah, as director of the Child Wellness Lab at Stanford, I would strongly urge that these long-term studies include, other aspects of wellness rather than just liver health.
Yeah, I agree. Thank you, Sunny.
Well, with that, let's thank Dr. Ebel for a wonderful talk.
Thank you.